Okay, so how to take a gynecological history. Now, I get asked this question quite a lot, and I found out by just speaking to the juniors that most of the juniors are quite apprehensive coming to gynecology clinics because they don't know what questions to exactly ask. Also, they don't want to feel embarrassed in front of a senior when they haven't asked all the appropriate questions, which the senior would like answers for before they come up with a management plan. So age is very, very important, like any in any history taking, more so in gynecology because we will be tailoring our management plan based on the menopausal status. Also, certain surgeries that some of them we're more likely to offer at a more advanced age than at a younger age. For example, a patient with prolapse who is, say, in their early 30s. It's a decision you want to really consider properly before offering them surgery, for example, for the prolapse. Whereas in somebody who is a 50-year-old, 60-year-old, a prolapse surgery would be recommended along with other options as well. So age is critical. You cannot come to a senior with a patient's history without knowing their age and their menopausal status. Within the menopausal status, you have to know the last menstrual period if they are still menstruating. You then want to know why they've presented to the gynecology clinic. Now, the usual things will be either vulval pain, vulval itching, abdominal pain of any sort. There will also be irregular bleeding, heavy bleeding, vaginal discharge. Now, those are the common kind of presenting symptoms that we see in gynecology. Now, you want to explore a little bit about these symptoms. So, how long have they been ongoing for? Are there any associated symptoms with these problems? Is there any family history of gynecological issues? Does the patient have any other previous gynecological issues that they needed to come and be seen in a clinic, for example? Like lots of patients have history of ovarian cysts and they then represent with cysts. Now these patients will then already come up with an idea of what management they would like for this presenting symptom. So it's important to explore this with the patient before you carry on. Now once you've taken that history, you then want to find out about their cervical smear history. Very, very, very crucial and important. So if a patient's coming with irregular bleeding or postcoital bleeding, this history becomes very, very relevant because this will then determine whether this patient will need referral, an urgent referral to colposcopy, and so forth. Parity. So in gynecology, you cannot get away without asking the parity of the patient because if somebody is a nulliparous and somebody is parous, that means they've had children before. The management options vary. Also, the kind of scans we offer them, the kind of things we offer in the future will vary depending on whether this woman in front of you has had children or not. Um, Surgical history, so especially abdominal surgery is what we're interested in because this again will determine whether this patient, if they are offered surgery, how complicated is their surgery likely to be, and keeping that in mind, the patient will need to be counseled appropriately about their risks. So somebody who's never had any surgery on their abdomen, their risk of having, say, damage to bladder, bowel, ureter is less likely than somebody who's had repeated abdominal surgeries or has got history of endometriosis or pelvic inflammatory disease. This is why all of this becomes very, very relevant. So, age, which includes the menopausal status, the last menstrual period, the presenting complaint, the history of presenting complaint, the cervical smear history, the parity, the surgical history. Then moving on to things that you would cover in any history taking. So medical history. So what other medical problems has this patient got? Now this will influence our management in terms of, for example, if we listed this patient for surgery, whether this patient needs to go and see the high-risk anesthetic clinic, whether this patient needs a bridging plan for their, blood thinning medications that they might be on, and so forth. Medications they're on, especially HRT, allergies the patient's got, the BMI of the patient if they know, or you can include this in the examination. Social history, so who do they live with? Are they independent and doing most things for themselves, caring for themselves? Have they got somebody at home to look after them if they did end up having any surgery? Any alcohol use, any smoking, any recreational drug use is all relevant. In terms of examinations, you would first start off with a speculum examination, followed by a vaginal examination that's also called as pelvic examination, where you have the feel of the cervix, the adnexia, to feel for any masses, any bulkiness in the adnexa, and so forth. And then abdominal examination, which helps you to identify any pelvic masses, any tenderness within the abdomen, whether the abdomen is soft, and these will then determine what kind of management you offer the patient. The management plan now usually you will be discussing with a senior colleague, but it will either include requesting more imaging, more blood test, or listing the patient directly for surgery, in which case your patient may need consent form signing, which usually your senior would be able to help you with. I hope this was useful for you as a quick history taking little tutorial. And as you can see that most of these questions are something that you would ask any patient, but there are the specific ones that you want to ask a gynecological a patient who's coming with a gynecological problem, because this will influence what kind of management we offer them. If you found this video useful, then please give it a thumbs up and subscribe to my channel and leave a comment and tell me what was the most useful for you. Thank you all for watching.